I now introduce myself. I will do the second presentation about the French experience. I will keep the microphone and I will step behind to see my slides. It works. I'd like to start my presentation with two clinical cases for a general reflection of us all about pregnancy and vascular EDS. So we have the first case. It's a 30-year-old patient, nulliparous, with an inherited COL3A1 variant with a glycine substitution. She doesn't have any vascular history. She is known, or the whole family is known, for being non-compliant to any medication. In France, it happens to be celiprolol for prevention of cardiovascular events. She is now in a stable relation considering pregnancy. That was a few months ago. In the second case, we have a considerably older young female, 30 years old, nulliparous also. She has a new mutation, also a glycine substitution. She has and is adherent to treatment with celiprolol and ARB. She has important vascular history, and at 38, she also considers pregnancy at last, as we all thought she wouldn't. If we look at the vascular imaging or workup in these two patients, we discovered in the first case a dissection of the right internal carotid artery, a small aneurysm of the right vertebral artery. She has a sister with vascular EDS, a mother with vascular EDS, and a grandmother with vascular EDS, and all three had children without any obstetrical event that has happened. For the second case, you have here in the images numerous arterial defects. The most impressive one is here on the upper right, the aorta, which shows a dissected aorta with a significant enlargement, and that would be right where the gravid uterus would develop. So how would you counsel and advise these two patients? So I'll leave you a few minutes of reflection. We probably would all have the same counseling for these two. We'll see a little later how these two cases developed. You all know, or we all know, that in 2011 the ESC issued a first series of guidelines on management of pregnancy in patients with connective tissue disease. Amongst them was vascular EDS. These were updated in 2018, and the ESC still had a very firm position on vascular EDS, considering pregnancy during vascular EDS as a very high risk. It's not only high risk, but very high risk. They recommended to advise all women not to become pregnant, so it's a kind of a formal contraindication for all patients with vascular EDS to become pregnant. Of course, that is not the reality of what is happening, and that doesn't take into account different types of mutations that bear very likely different kinds of risks. Come back to the larger study about obstetrical complications by Peter Byers' group that was published in 2014. Initial mortality estimates began at 38%, then went down to 25%. These were case series. In the year 2000, in the New England Journal of Medicine paper, it was evaluated at 11.5%. And it went down with increasing numbers of patients in the series to a more realistic mortality of 4.9 to 5.3%, the 4.9 being the whole cohort with patients with haploinsufficiency. And if you remove these patients from the analysis, the mortality rate The pregnancy-related mortality goes up to 5.3%. And of course, it's likely that the more you increase the cohorts, the more close you would get to reality or the real mortality rate in this condition. So this is much less important than the initial estimates. It is, however, up to 300 times more elevated than in the general population. So that's a good illustration about the biggest problem in pregnancy, for pregnancy in vascular EDS. This paper also evidenced that there was no effect of the pregnancy on the life expectancy of women with vascular EDS, to the least that it doesn't have any pejorative effect or precipitating effect on the arterial involvement in vascular EDS. So you have the left figure with the whole cohort, and the right figure is only the probands with similar distributions between parturients with vascular EDS and nulliparous women. There are small limits in the comparability of these two groups because we don't know exactly if the nulliparous women or why they didn't have any children. Still, they were younger than the others, then most likely they didn't have the time to have children. If we look at the same figures in France, we did an analysis in our cohorts, in our patients in Paris. We have 98 parturients that have had 156 live-born children. And that is, if I go back to the previous slide, 1/3 of the American patient population. And you see when American women have 616 deliveries for almost 300 patients, the French have only 156, meaning that American women have 2 children and French women have 1.5 children. So I don't know where that comes from. Why do the American women have so many children and the French don't? I don't know. Still, we did a pedigree study that went up to 2 to the second degree ascendants, and we calculated the mortality rates, the pregnancy-related mortality, late maternal mortality, that is the death of a woman between 42 days after delivery and 1 year after delivery. And we combined these two in an overall mortality rate that was calculated to 6.4%. The pregnancy-related mortality was 5.8%. I'm not sure if this is readable. The confidence interval is quite large. It's from 2.7 to 10.7. That's because there are not many patients. Quickly, the obstetrical outcomes, there is much information in this paper. Quickly, just the prematurity, 14% was evidenced. There are severe lacerations, 21% of patients, that of course is associated with vaginal delivery. PPH, 10%, that is associated with C-section, and there were premature rupture of membranes in approximately 20%. And notably, a big majority of these patients were delivered without being diagnosed with vascular EDS. We have the same figures in our cohort. We have similar findings with preterm labor and premature ruptures of membranes of 20%. Preterm births, which are a little bit higher at 40%, but it's a smaller size sample. Bleeding is similar with 10% PPH. There's a high amount of perineal tears at almost half of patients with vaginal delivery had that, so that's a real concern. These are only patients with dominant negative variants. So the pregnancy management protocol in France starts with a preconception multidisciplinary counseling. It goes through the history of disease. It discusses arterial imaging if it is necessary. Treatments have to be adapted. As Glenda says, ARBs and ICAs are not compatible with pregnancy. The beta blockers are celiprolol are continued as before. The PGD is being discussed ideally with the patient or the couple, and most importantly, the couple is informed about the risks of pregnancy. PGD would not be refused in France, as we heard before. Couples would not be denied of a PGD because the mother is likely to die someday or prematurely. That is not an argument. The follow-up of pregnancy is obstetrical. It's a monthly outpatient visit, and then more frequent by the end of the pregnancy. Patients, of course, know about the risks and must solicit medical attention if any unusual symptoms occur. The cerclage is not systematic. It has pretty low figures. Also in our observation and in Mitzi Murray's paper also. Premature, the problems that was said before, is increased. So there's a risk of prenatal birth. As Glenda said, antenatal corticosteroids are systematic in our series. We do not do systematic arterial monitoring in our pregnant women. I don't know if that would be a good thing to do or not. That can be discussed. The final choice of mode of delivery, we don't have any good literature on which is the best mode to deliver patients. It's possible that vaginal delivery could be a possibility for patients with haploinsufficiency. For patients with dominant negative variants, it's more likely or maybe safer to do a C-section. In clinical practice, that is what often happens. Patients are delivered between 35 and 37 weeks of amenorrhea. Of course, as Glenda said, vascular surgeons must be informed that this is happening, and the best thing is that they're scrubbed in. In France, it is difficult to have that kind of assistance, to have the surgeons in the same operating room, but that's the very best thing to do. The postpartum is, of course, at high risk of complication. There are several recommendations on thromboembolic prophylaxis, on contraception. There is no early dismissal in our patients. Breastfeeding is controversial. Very often in France, our obstetricians do not want women to do breastfeeding because of the cell or beta blockers in general. If the patient decides for breastfeeding, should not be prolonged to prevent fatigue and cutaneous lesions of the mom. And if we come back to our two patients that we have left behind a few slides before, what are the outcomes? Of course, I think you would have allowed a pregnancy in the first case. There seemed to be no obstacle. And in the second case, I think anybody would have contraindicated pregnancy. And let's see what happened. In the first case, it was a spontaneous pregnancy. It was totally uneventful. And 1 week prior to programmed C-section, the patient developed moderate chest pain, lateralized on the right. She was ruled out for pneumothorax pulmonary embolism. She did get a CT scan of the aorta, but it stopped at the diaphragm. And when they, 1 hour after the CAT scan was over, she went into cardiocirculatory collapse, and most likely an aortic rupture occurred. The baby was extracted in emergency, and all attempts from the cardiac surgeons to resuscitate the mother were in vain. For the second case, the pregnancy was contraindicated, and the lady became pregnant anyway, because you cannot, if a woman wants to get pregnant, she gets pregnant. Pregnancy was totally uneventful. The delivery was uneventful. Unfortunately, at day 3, she ruptured her abdominal aorta. She got immediate surgical repair, but that was too late, unfortunately. So I will skip this part because I'm terribly late. Just a quick word. 14 C-sections. The two patients died. These were the 2 patients that you've seen before, on the slide before. All the other procedures were went well. So I think we have a problem with numbers, very low procedures and low numbers. So We don't know the real effect of C-section, the protective effect, if it has one or not. So in conclusion, I would like to say that it's important to know better the outcomes of patients with haploinsufficient variants. I think that is something important to study. Of course, patients need to have a multidisciplinary counseling for the couple. That is very important because after, if something happens, it's a catastrophe and people don't understand what has just happened, and the doctors don't either. Of course, if there is some pain, unusual pain, and imaging of the whole aorta, including abdominal aorta, is paramount. I'm very, very late, so I'm sorry. This was a bit longer than it should have been, but I'm done. Thank you.